Hi everyone, it's Sue and I am pretty excited. I am going to just play a little bit here if you don't mind. So I've recorded lectures already and I've posted them for weeks 1 and 2. Week 1 we focused on some things like thinking biases, the focus of the course, the outline, the assignments. We also started with that understanding of vital sign interpretation, not taking vital signs, but interpreting them and really looking at the pattern, right? So that basic concept is physiological compensation happening here. Do I recognize the pattern? Is there an explanation that could be forming that helps me to understand what's going on? And if that's a good thing or not a good thing? And if compensation is not happening, what is the mechanism that is failing here? And so that's, I think, a really important concept because it takes your analytical ability up to a higher level because you're looking at a bigger picture. They're really understanding physiologically what's happening. And that helps you to sort of jump the queue, really get to the heart of what you're seeing in I think, a much more refined way. So I thought we'd spend a few more minutes, if you can stand it, going over that. I know I recorded, but it's a recording not from like just last week. I recorded that before. So I'm going to do it a little bit more informally here, and hopefully that makes sense. I had a request also to put the camera on. Yikes. And so you see the COVID-20, which is putting it mildly, and also the shutdown of my hair salon. So this is me and I guess the final confession. I'm wearing my pajamas. Okay. No more truths about me, or probably by week 12, we'll know everything. So if you can stand it, and while my good friend Leslie Graham has taken my kids out for a walk, and we are, okay, we're in the same, honestly, we're in the same bubble because she has to help. This is just a review, and then we're going to talk a little bit of review of fluid and electrolytes. So to the heart of things, let's start with the normals, and you know it, although sometimes I talk old times instead of new times. So please don't hesitate to correct me or to translate for yourself. All right, I'm using whiteboard for the first time here, and I'm not very good at it. So temp, normal temp, typically 36.5 to, I always say 37.5, but now we've gone to what? 37.8. Heart rate, 60 to 100. And let me just clarify a point I wanted to make. We know, and we'll talk about this more when we get to our cardiac modules, that 60 to 100 is the innate firing frequency of the SA node, the sinoatrial node. And so the human heart is designed under normal circumstances to initiate an impulse of 60 to 100 beats per minute. But we talk a lot now about 50 to 60 as often not being too concerning, that it may be just a measure of, let's say, a healthy heart, someone who's very fit and their heart is able to pump much more efficiently and other kinds of things. So 50 to 60, we put in brackets, right? Because depending on the circumstance, I might be thinking that is a reasonable heart rate and I could account for it. It may not be concerning if other vital signs are all fine. That may be just fine. If somebody's on a medication that may affect their heart rate, for example, a beta blocker, which is going to decrease someone's heart rate or prevent their heart rate from accelerating under certain conditions like activity, then again, I might be able to say, that's what I might expect. But there are other situations in which I wouldn't expect this. So we're not expanding the range. We're not saying normal is 50 to 100. We're saying 50 to 60 is just in a gray zone, right? Gray zone. I think about it. I ponder it in a way that I might not ponder a heart rate of 72 as much. But although in this process, I say we ponder everything. The other part of that is the 90 to 100. And I think, again, we know the SA node is set up to fire all the way up to 100 under normal conditions. But the 90 to 100, we're also going to ponder, and just ponder because we're getting to the upper limit of normal. We're going to ponder again, is someone's resting heart rate 96? And if it is, are they comfortable at 96? Is there something that would explain why their heart rate would be beating that quickly? Again, it may be absolutely no concern at all, but it's just we're putting brackets around it. We just put some brackets around it and say, is that okay? Is there something else going on? So we're not changing the standards. I would say the standards will at some point help us with that sort of clarity, that putting a little bit of a bracket around. That's all. Respiratory rate, the norm, what do we say? 12 to 20. And again, I'm going to put a bracket around 12, unless somebody is sleeping, incredibly fit, a couple of other things. 12 is a pretty low respiratory rate for someone up and around, walking, other kinds of things. 20 is getting up high, right? So again, I'm going to look at a whole bunch of other things. Age, medical conditions. Has somebody just walked in and sat down in the chair in the clinic, or what's going on? So 12 to 20, again, as with both things, I'm putting a bracket around the upper limit and the lower limit just to pay attention, right? And then blood pressure. Do you remember in the old days, we said the upper limit was 140 over 90. Now we have this, right? 120 over 80. And that really represents, as much as when we talk about heart rate, we're going to bracket those upper and lower limits. Changing the standard around what is hypertension and where we want to look to intervene is really a measure of our much greater focus on prevention, right? So prevention of cardiac event and cardiac illness as opposed to treatment, right? We've moved much more to prevention. So we know it's important that we look at that blood pressure more in a more refined way. So upper limit is 120 over 80, lower limit is 90 over 60, typically. Now, it could be that when we're as with all other vital signs, we're also going to look at what somebody normally runs at. Are they on medications? Is there healthcare team, so their primary care physician or other kind of medical practitioner, happy with where they're running? If they run at 132 over 86, is everyone happy? Because you're managing a whole bunch of factors there, right? So it's recognizing that these are the norms. These are the norms of where we're at. But we also pay attention to someone's history, medications they're on, the condition they're in. Again, have they just trekked in from the parking lot and sat down to have their blood pressure checked, as opposed to waiting that, maybe 10 minutes sitting down before you do that. And then finally, we're going to look at O2 sat. I'll put a little box here. O2 sat, one of my favorite things to talk about, because high acuity, and we're going to talk about this throughout the course, and I am sorry if I'm repeating myself, because this is just off the cuff. O2 sat is something, a little bit of a pet peeve of mine, because there's two risks. One is that we don't intervene. So somebody has an O2 sat of 88, and look, I'll clean that up a little bit. And we put on 2 liters of oxygen because we think I'm allowed to put on 2 liters. I'm not putting on 2 liters. Now, you may have some kind of directive, a standing or other kinds of things that tell you that you can put on 2 liters without a physician's order beyond that. If 2 liters doesn't get you to where you need to go, then you need to get a physician to see that patient then, right? So 2 liters is not magical, and I'm not really sure why we always see this 2 liters, except that often that is what we see in institutions as sort of a delegation, right? That you can put on up to 2 liters. I would just watch that and watch your thinking around that, right? Because you're always titrating oxygen to what is appropriate. And where we want to go with oxygen is 94% and above. So ideally 95, but anybody below 94, ACLS tells us that we need to provide oxygen. And we'll talk a lot more about this, oh my gosh, when we get to when we're doing ABGs and we're doing a respiratory system. But there's a couple of points I want to make here. One, everybody is paranoid about COPD, CO2 retainers. We give them too much oxygen, then we'll decrease their respiratory drive. They'll have a respiratory arrest. That is physiologically true. Some patients with COPD are CO2 retainers, and when we give them higher doses of oxygen, their respiratory drive is suppressed and they may have a respiratory arrest. First of all, we're watching that, so that shouldn't happen right in front of our eyes in an unexpected way. Secondly, this is a very finessed process of understanding where someone's O2 sat should rest. So if someone has COPD, it's important to recognize that does not mean they are a CO2 retainer, right? Only a subsection, a small subsection, or relatively small subsection of patients with COPD are CO2 retainers. Now, until we know one way or another, we are always cautious, but that doesn't mean we allow patients to become hypoxic because we're being cautious. What it means is that we seek guidance, right? In the UK, there's a really important movement towards making patients or having patients carry a card when they're a CO2 retainer that says they're a CO2 retainer and the ideal range for their O2 sat. So I'm a CO2 retainer, my ideal range for my O2 sat is 89 to 91%, something like that. So people know what where you're going, and or a card that says I have COPD, I'm not a CO2 retainer, oxygen is a reasonable intervention. So we'll talk more about that, but that idea of being overly cautious with patients who have COPD so that we allow them to become hypoxic is really problematic. And even if someone is in acute distress, a COPD patient is in acute distress, remember we're talking higher acuity, we're going to oxygenate them, even if it means we may have to intubate. And we don't want to intubate a patient, so we have lots of other options that we're going to try first and to really support a patient, but we're not going to allow the consequences of hypoxia to occur just because we're worried about that process that may happen, right? Because we have the opportunity to intervene. That's something we're going to keep coming back to. The one thing I will say is on the NCLEX, or on when you write your registration exam, that's likely they will want you to be thinking about that process. Everybody is, so attuned to that process. Excuse me, they want to overgeneralize it. So be aware of that for the NCLEX. Of course, questions might be, cueing you to go there. I'm talking about real practice. We don't let patients become hypoxic unless there's a discussion about ideal O2 sat for this particular patient. And some very fragile COPD patients, ideal O2 sat may be 88 to 90, 87 to 89. Like there are very specific patients, and their respirologists have worked to determine what is their ideal oxygen saturation and what consequences arise from that. So we work with the team always, but we're not going to let that overly influence us. The other side of that, and this is really critical. Let's say somebody has, is this too messy for you if I go up here? Let's say somebody has an O2 sat of 91. And you decide, because I have a medical directive that says, or a delegation that says I can provide 2 liters of oxygen, I can give them 2 liters. So I give them 2 liters and their O2 sat goes up to 94. Am I happy? Well, remember I told you ACLS guidelines say anything less than 94 and we're going to provide oxygen, right? 95 and above is a goal typically for adults. For children, it is an absolute goal. For adults, it is typically a goal, with 90 to 95 being a little, again, a gray area. Above 90 sometimes is considered acceptable, again, depending on a lot of circumstances. I just want you to have an open mind about this and understand that there's no just one single answer for things. So there may be times when 91 is okay, depending on someone's medical condition. But in this case, 91%, they don't have any particular medical condition that's leading you to believe that they don't require oxygen. You put on your 2 liters because you think you have a directive for that. It's in the order set in the hospital. Their O2 sat goes up to 94%. Are we okay with that? Too easy to say yes. You know why? Because in the absence of determining what the work of breathing is, I have no idea what's happening with that person. So for example, when RTs talk about work of breathing, it's chemical equation that they talk about. I'm going to talk about it differently. When we talk about the assessing a patient for the work of breathing, I'm trying to get to an understanding of how much work is it taking that patient to get to that oxygen saturation of 94%. So I don't just put on that oxygen, say, phew, we're up to 94, we're good, off I go. I'm going to look for specific things. Do I see nasal flaring, right? Their nose is opening up like that. Do I see them with adults raising their shoulders as they breathe, right? They're using those accessory muscles. I may see that you have some indrawing here and in here. I may see in children, and we're typically, this course is talking about adults, I look at a tripod, which is intercostal indrawing, nasal flaring, and you have an indrawing right up here, a tracheal tug. But back again to adults, I'm looking at how much work, and a really good indicator is how many words can they say in a sentence? Are they speaking a full sentence like I am between breaths? Or are they speaking in a way that they have to take a breath between words? So for example, I came to see the doctor because, and if that somebody is breathing that way, I describe it in those words. Breathing 1 to 2, so that's a 1 to 2 word sentences. And so the sentence is where you stop and have to take a new breath. And that's so important. So this is not like I have a paper that has a lab result. It's great to have ABGs, but until we have ABGs, and if I'm on a floor, if I'm in a step down and I don't have ABGs available to me at the moment, a patient just arrives, I may be working in rehab, I may be working in long-term care. One of the really important assessments that goes along with understanding that O2 sat, the respiratory rate for sure, the level of accessory muscle use, that work of breathing, do I see nasal flaring? Do I see any signs of that they are tiring? So how many words per sentence? And when you report it, if you were going to give that SBAR report, you would use just that universal language that talks about how many words per sentence. So speaking in 1 to 2 words per sentence, 3 to 4 words per sentence. That enables you to communicate effectively to the physician. Not only has the patient came in with an O2 sat of 91, or on rounds, I found my patient with an O2 sat of 91. I applied 2 liters by nasal prong and their O2 sat is up to 94, but the patient's respiratory rate is 24. I'm seeing nasal flaring and accessory muscle use, and they're only able to speak 3 to 4 word sentences. That is really important because that assessment of how hard they are working to get you to that 94 tells you about the risk for tiring, right? So I don't want to wait till the person is so exhausted they have a respiratory arrest. In layman's language, they poop out. I'm not waiting for a patient to tire so much. They've made it to my threshold of 94, but they're hanging on by their fingernails. That number 94 is not so important as all that assessment that I'm saying. They're using everything they've got, all the, their body's compensating as much as it can, but that's not going to last long. And so it's important that we don't throw away that time, that we say, aha, I'm able to help them to be able to get enough oxygen so their saturation reaches an acceptable level, but that's not going to last. And this is where we would be looking for alternatives. In this situation, I would need a physician to assess the patient right away. If I would expect that I would have some different orders that we're going to move to something again. All things being equal, it would depend on a whole bunch of things, including diagnosis, code status, what's been happening with the patient, other things, assessment, my hearing crackles, what's going on with their respiratory status, looking at their other vital signs, but other kinds of oxygen. So it may be that I need to move to a higher flow of oxygen. So not 2 liters. Nasal prongs when somebody is in respiratory distress are least adequate because often you become a mouth breather, right? So when you're mouth breathing, you're getting very little oxygen from that passive nasal prongs. I may move to, let's say, face mask, not much of an improvement. I may move to CPAP or BiPAP. That's going to give me some of that flow that helps to decrease that work of breathing. I don't have to work so hard to inspire because there's a force of that oxygen coming in. So it's not all of my effort to inspire. I get some help with that. And that may help really significantly in decreasing the work of breathing. Another really game changer in oxygen administration is Optiflow. Typically the RT is going to work with you with that, but you see that on TV all the time now when they're showing you patients who have COVID. How can I forget that? Patients who have COVID where they have that very large prongs. Again, it's not CPAP in that it's not that big mask. And you see that large oxygen prong, and it gives you that flow again, that forceful flow that really, really assists with oxygenation. We may move beyond that to preventive intubation. You would rather intubate a patient in a preventive way that we see the patient is in respiratory distress and I'm not able to turn it around, versus having a patient have a respiratory arrest and have to respond to that, right? So it's watching all of that. So it's not just the numbers. The numbers are always in context with everything else I see. And that is so, so, so critical. So enough talking. Oh my gosh, I hope this isn't boring. So let's erase these normals. You all know the normals, right? Everybody knows the normal. Temp 36.5 to 37.8. Heart rate 60 to 100. We're just bracketing the lower end and the upper end just to pay attention. Respiratory rate 12 to 20. I'm bracketing lower and upper end just to say what's going on here. BP 90 over 60 is the low end, 120 over 80 is the upper end, but lots of patients, particularly older patients on many cardiac meds, other things, there may be, their physician may be very happy with a blood pressure that's slightly above that. So we're just going to pay attention. O2 sat, Remember, we want definitely always O2 sat above 90, because do you remember that oxygen dissociation curve, that when your oxygen saturation drops below 90, there is less attraction between oxygen and your hemoglobin molecule. So you tend to have that rapid drop off of the amount of oxygen carrying capacity of your hemoglobin, or the capacity to draw that oxygen in. So below 90, you may have some small subset of the population that would run slightly below 90, but not much below 90. And those people would be well identified, right? You're working with our respirologist already, well identified. Typically, we're always paying attention to 90, even as we're trying to bring somebody's oxygen up. Anything below 90, we're thinking critical, unless there's something we already know, we've already established it, right? Anything below 90, we're thinking critical, because that drop off on that oxygen curve, right? That, oh my gosh, sorry for my block, but on that oxyhemoglobin attraction curve, sorry, that's not the right word, dissociation curve. There is ACLS guidelines that are telling us anything above 94, we're typically giving oxygen, and we know the standard 95 to 100 is what we're considering now normal. But whenever we're looking at respiratory rate and O2 sat, we're also looking at that work of breathing. You cannot look at those numbers without work of breathing. So the numbers can never speak for themselves. Okay, fair enough? All right, let me try to erase some of this. Let's see if I can erase. Oh my gosh. Sorry, I'm like so proud of myself. I'm proud of myself for turning on the camera. Is anybody else feeling like it's just crazy times? Okay, let's try a new color, red. Oh, so should we practice some vital signs? And then we're going to look at that process of compensation and the direction that it happens in, okay? So let's look at some vital signs. 36, 9, 74, 14, on 32, on 78. 95%. Okay, so I look at each one of these. 36.9, normal, abnormal, anything going on? I say good. Everybody with me? 74, range member 60 to 100, gray at the 50, gray at the 90 to 100, 74, looks good. 14, prairie 12 to 20, looks good. 132 on 78. I'm going to just put a question mark there just for a second. Remember we said, what is the upper limit of normal? 120 on 80. And 95% O2 sat, we're good. Now, so this 132 on 78, am I going to go crazy over that? No, I'm not. It's a little bit above. I might ask questions. What's your normal blood pressure? Other things. If this is 18-year-old who's otherwise, well, nothing going on, I might ponder what's going on. I might look if there's a pattern. Do we have a history that gives us a previous blood pressure, other things? But we're pretty undisturbed by this. We're going to note it, right? We're going to note it. And I see nothing else happening in these vital signs. So I'm going to note that. I may draw it to someone's attention. And I would also, for sure, always look to see, do I have anything else, any other previous blood pressure? If this is a patient who's just come in, let's say you're working in a clinic, they've come in, sore throat, here for a throat swab. I might do their, and we've done the throat swab, doctor's writing a prescription, they think it's strep. I might just do one more blood pressure just to check. You know, remember there's that white coat syndrome, and also just when somebody first sits down, if we don't give them 5 minutes or so, it may not be totally accurate. Okay, so we're good with that, right? Ticks, how easy is that? Let's try another one. Oh my gosh. All right, ready? Okay, now it's hard to just look at vital signs without any history. So I'm going to give you a little story that makes sense with them, right? Let's say here we have a 36-year-old woman who's complaining of burning on urination for a week, much more significant. She has fever and chills that brought her in, and some flank pain, so pain up in her back. And here are her vital signs. 39, what do we think? Happy, not happy? I'm going to make it a different color. I'm going to say circle, not good. 110, happy or not happy? Yeah, not into my normal range. 22, happy or not happy? No. 110 on 80? Okay, 96. Okay, and do you remember the 96? I'm looking at all of the other things, the workup breathing that goes into that. So let's take a look at these vital signs. Now, remember I told you she has a history of burning on urination and now flank pain with chills. So sometimes you get chills with a fever, but just, I'm going to sometimes tell you things that are just a little bit of a rule of most common reason that you would have chills, most common, if you see a patient who is new to you, who has is describing Riger chills, would be pneumonia or a pyelonephritis, which would be like an infection in your kidneys. So she has a fever, right? So it's up, heart rate is up, respiratory rate is up, everything else is okay. The temperature being up may be a primary source. None of these other things in terms of compensation lead to an increased temperature. So if you had let's say your heart rate was low, you were you had a low heart rate, or you had a low respiratory rate or a high respiratory rate. None of those things affect temperature, but temperature affects those things. So that's really important to keep that we don't, that we understand that compensation, sometimes we see it both ways, sometimes only unidirectional. So a temperature of 39, you've got a fever. How may that impact heart rate? So sometimes it doesn't at all, but seeing a slight tachycardia like this, 110, it wouldn't surprise me. So I might say I see a compensation potentially. Remember, I'm not ever diagnosing, but I see a potential compensation with a high fever of 39 that I may see a tachycardia, a slight tachycardia. I'm not going to see 160. But if I see a slight tachycardia of 110, it may be absolutely related to that fever. Does that make sense? And compensation, remember, physiological compensation. Why would I see a tachycardia when I have a fever? What does your body want to do? So your body wants that flushing to occur, right? It wants you to be able to get rid of that excess heat. So you've got that flushing that's going to happen, and you're going to be able to circulate your blood volume around to get it to the surface to cool. So you're going to have that a slight tachycardia. That would be somewhat compensatory, potentially. We're always saying potentially. And we're coming back again to our primary thing, 39. Do I think there might be any relationship between that fever of 39 and an elevated respiratory rate? Yes, because another way we cool is through that breathing in and out, right? Breathing out that hot air, breathing in cooler air. So a slightly, again, depending on a lot of things, a slightly elevated respiratory rate, slightly, may be associated with fever. Okay, so do you see? But those are unidirectional. It's not like a respiratory rate of 22 causes a fever. It doesn't. It's unidirectional. Do you see? They both have arrows just going one way. The fever has no impact here on my blood pressure. In other situations, it may, right? And O2 sat of 96 is okay. I see when I'm looking now, I'm continuing to move my way across. So I've started with my temperature, and I've looked at all the other vital signs. Now let's go to my heart rate. 110. I've already done temperature, right? We've started there. So 110 is my heart rate. I don't have to go backwards to temperature, but let's see. 110 is a heart rate. Does that have an impact on my respiratory rate? It's just a mild tachycardia. I think likely there's not a relationship, right? A heart rate of 110, unless it's a primary focus, I might just say question. Is there a relationship between those guys? 110 and 110 over 80. Now, remember I said my blood pressure is normal, so I'm not seeing a compensatory process here at all, right? Because my blood pressure is normal. It's all fine, right? So I'm not seeing anything happening there or a failure of compensation. A heart rate of 110 and an O2 sat of 96. I'm not seeing anything, right? My heart rate of 10 is elevated, but those are all fine. Now let's come to my respiratory rate. Again, I've done the first two. I don't need to go backwards. I'm just continuing to move forward. Respiratory rate of 22 and a blood pressure of 110/80. I'm not seeing anything, right? I've got a slightly elevated respiratory rate, but nothing with blood pressure. Slightly elevated respiratory rate and an O2 sat of 96. The only thing, I'm not going to say I see compensation. The only thing I would say here is that if there is something going on, the person is coping with it physiologically well, right? So has a perfectly acceptable O2 sat. So what I would see here, and again, just at first glance, there's a whole lot going on. I want to investigate all of this. The best of a high acuity nurse is that I'm an investigator, is that that the patient is febrile with a compensatory tachycardia and tachypnea, very mild tachycardia and tachypnea. Do you see the cue here? Both of the compensations come from the fever. So the patient is febrile with slightly with compensatory mild tachycardia and tachypnea. Okay, let's try. Does that make sense to you? And do you see why it's helpful? Instead of looking at all these things as random pieces, I want to make a story out of them. I'm not stuck to the story. Remember we talked about thinking biases. I don't bring all kinds of information in that fits that hypothesis. That is one hypothesis, and I'm going to investigate it always with an open mind for something else, right? Always with an open mind for something else. But let's erase that. Okay. And I hope this is helpful. I need to hear from you guys if it's not. And let's try green. And discolor. Okay, so let's try something else. Okay, 35.2, what do we think? Now it's an interesting thing. We're going to tuck this away. We're always looking for a fever. When somebody has a low temperature, sometimes and a lot of times it means nothing. So, you know, you're always looking to say 36.5 to 37.8 is normal, but anything, or 37.7 is normal. But so if it's lower than 36.5, are they hypothermic? Typically not, right? So typically not, but they might be, and it could be cold shock, right? So we're in the beginnings of shock, if we have a septic shock, we may see an increase in temperature and then a sudden drop that actually goes below normal. But so what I'm going to do is put a big question mark there because I don't know, right? I don't know. And because I don't know, I'm not going to try to associate it with anything. I just don't know. So my personal temperature always runs 36 or below. Many patients, you'll see that. So I would just pay attention to that. They might have just walked in from outside. I don't know. I'm going to put a question mark there. 138. In any kind of reality, is that okay? No. Let us change this to red. No, no, no. Up, right? And it's significantly up. So 138 tells me that the person is tachycardic and significantly tachycardic. But again, all things being equal, and they never are. If my patient is 17 and they've just run a marathon and they've sprinted the last 400 meters, 138, maybe, okay, but we're always gonna, you know, understand the context. 26, what are we thinking about that? Normal? No. Tachypnic. So we're putting that up again. So it's 16-year-old running a marathon, having sprinted the last 400 meters. 82 on 52. What do we think about that? Okay. No. Low blood pressure. If I had a 16-year-old ran a marathon, sprinted the last 400 meters, I probably would not have this low blood pressure, because even for a young, healthy person, they would typically not be so hypotensive in the face of such aggressive physical activity. So, but regardless, my blood pressure is too low. 92? Nope, too low again, right? So 92, too low. So what am I looking at here? I've got a tachycardia and a tachypnea and a hypotension and a low oxygen saturation. So let's look at this. We're coming back to that idea of compensation. Heart rate of 138, tachycardic. What happens in the face of tachycardia, right? So our heart is beating very quickly. We're pumping that blood around very quickly for some reason. We don't know what that reason may be. There's lots of physiological causes. Could be I have an anomalous heart rhythm originating from someplace in my heart, other kinds of things. I could be in shock. A whole bunch of things could be happening, but I've got that tachycardia. In the face of that tachycardia, one of the compensatory processes that our body wants to bring to bear is an increase in respiratory rate. And that happens because as our heart is beating more quickly, our heart itself has increased oxygen demand, right? So we want to make sure that our heart is adequately oxygenated. So if you think of that systole, diastole, it's only in that very short period of diastole, the rest, that our heart is actually able to be to have that oxygen cross over the capillary walls and actually provide that oxygenation to our cardiac cells. So the challenge is, as our heart is working faster, it needs more oxygen itself, or you're going to end up with cardiac ischemia. And so our respiratory rate typically would go up as our heart rate goes up, so that we are able to provide more oxygen to nourish those cardiac cells, right, which are having a shorter, they're requiring more oxygen, and they're also having a shorter period in which to receive that oxygen. So I'm saying typically, lots of things could be whatever, but I'm pondering is that a tachycardia with a compensatory tachypnea. Right? May not be, maybe something else, a whole bunch of things could be going on, but it may be. The other thing is that I might have, do you see this tachypnea? I might have situations where I am acutely short of breath and I become tachycardic because of that. So that compensation, do you remember we talked about temperature? Temperature compensation occurs in one direction only. When we're looking at other vital signs, they can occur in both directions, right? So in this case, I don't know, and it's really important I have an open mind. So there's a difference between a patient who may be looking like they're in septic shock, a cold septic shock, or a patient who may have a pulmonary embolism, be breathing very quickly and have a tachycardia associated with that. You see how I don't want to make a diagnosis, but what I do want to do is look at the pattern. What is the pattern I'm seeing, and what evidence then supports the pattern and what evidence refutes the pattern, okay? So this could go either way. Now I've got a low blood pressure. When I have a heart rate of 138, does a tachycardia is compensation for a high heart rate that I would have hypotension? It would actually be failure of compensation. So what happens is, if my blood pressure is dropping, my heart rate speeds up to try to, as much as possible, compensate for that hypotension. If my heart rate by itself is rising, it is a failure of compensation that my blood pressure starts to drop. So either way, we need to be cautious. So I may be having compensation happening this way. I might have hypotension that's leading to a tachycardia, or so again, I'm going to say, you're not making a diagnosis. I might have failure of compensation happening this way. And my body's not able to compensate for the tachycardia, and I see my blood pressure dropping. Okay. Now let's look at the O2 sat. Am I seeing an association between a tachycardia and an oxygen saturation? When I'm tachycardic, Do you remember we talked about this whole process? I'm tachycardic. I increase my respiratory rate so that I can get enough oxygen to be able to have more oxygen in my bloodstream and be able to nourish my cardiac cells and other things. We're going to talk about shock in more detail, but shock is fundamentally a process where we see a lack of oxygenation right at the level of the cell. We often think of shock as, oh, that's bleeding out or it's this. Shock is a process whereby we see a lack of oxygen depletion at the cellular level. So there are lots of things that can lead to hypoxia. And I'm not trying to make a diagnosis. All I've got are these vital signs, right? But I'm trying to say, is there a pattern? Maybe, is there possibly an association? Yes, my heart is beating so quickly. It may be that I am not able to get enough oxygen to oxygenate that. So it may be, again, that there is an association, but it's not a good association. Again, it's a failure. Do you see? Maybe that I have a failure of compensation. This isn't helping. Now, would that work the other way? If I had an O2 sat of 92, would my heart speed up? Do you see how that doesn't really make sense as my oxygen sat drops? You may have a little bit of maybe a slight elevation. We're not going to have this rapid heart rate because my O2 sat is dropping. Do I see an association between my respiratory rate and my oxygen saturation? I may. Now, if we're going from 26 to 92, so as my heart rate goes up, should my oxygen saturation be low? Not necessarily, but I don't know what precedes it, right? I don't know if my oxygen saturation was 86 and now I've increased my respiratory rate and my oxygen saturation is coming up. So I'm just going to say there's an association between these two. I'm not sure in which direction because this is the first set of vital signs I have. So if this doesn't make you too crazy, I'm going to say there's something that could go either way, and I don't know. But there's an association. I'm tachypnic with a low oxygen saturation. So is it that I have a low oxygen saturation and that has led to tachypnea, or the tachypnea is from the tachycardia and I am not able to compensate adequately? I don't know, but there's an association. And then finally, my blood pressure is my lower blood pressure associated with my oxygen saturation. If I'm not able to perfuse my the cells adequately, my blood pressure is not high enough to pump around my blood effectively to be able to perfuse the cells with oxygen enough, then what I'm seeing here is, again, that failure, right? So I may be trying to compensate, I don't really know underneath, but I'm not meeting a reasonable oxygen saturation. The other part of that is that it could be that it goes either way. So it could be, do you see all of these patterns? Related, 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 not related. We're going through them. Now here we just had one set of vitals. Do you think that we go through this with every set of vitals we take? You all will, in your head. You're going to make sense. You're going to make a story out of those vitals. You're not going to come to premature conclusions. You're always going to have an open mind. You're going to understand the facts, observe your patient, do a full, clean health assessment, and really come to some good understanding of what the situation may arise. You don't ever want to treat based on diagnosis. What we know is the greatest risk to our patients is treating based on diagnosis, right? So you come to a conclusion about what the problem would be. Ah, I see here, this person probably is in shock. Tachycardic, tachypnic, hypotensive, low O2 sat. Let's get some IV fluid running. Let's do, let's put on some high flow oxygen. Let's do other things. Again, what evidence do I have to support that or not? I don't have a lot of time to make a determination, but there could be other elements that are having an impact on this. In this situation, I've got a heart rate of 138, but I don't know what the rhythm is, right? The rate is important, but we're going to talk about that in a couple of weeks. I have no idea what that rhythm is. So I really need to make sense of that rhythm. I've got a respiratory rate of 26, but I don't know what that person's lungs sound like. So even though their blood pressure is 82 and 52, what if this is a 90-year-old gentleman who is tachycardic, tachypnic, and has very congested lungs, already has fluid in his lungs, and we start running an IV bolus? So the risk is always that I'm prematurely jumping to a conclusion without that full assessment. Vital signs are one part of an assessment, and they're so important. I think we don't give them enough respect. Do you see how complicated it is to look through these? It's not a simple process, but every single time you take vital signs, this is the hallmark of an RN, but also a higher acuity nurse, where you're thinking about every little detail, right? You're thinking about every little detail. And so in this situation, I've got a lot of concerns and I need to validate. I need to listen to their lungs. I need to look at that. Remember, we talked about that work of breathing. When I see this 138, I need to know not just what is the rate, but what's the rhythm? What's the underlying rhythm? So is the primary problem cardiac versus the primary problem is something else? I don't know. And my goal is not to make a medical diagnosis, but it's to uncover information and look for those patterns. Do you want to try one more? Is this boring? You better tell me if it's too boring. If you know it all, if you're smarter than me, because I think it took me a while to really understand. I'm not just taking vital signs and I'm not just reporting something if it's abnormal. I'm really looking to understand, right? If our goal is to just really understand, then this is what I need to pay attention to. I'm going to do just one more. Okay. Well, this is my first time using the whiteboard. It's pretty good, right? You tell me again if you like it. Okay. 37, 2. Okay, so now let's go through them again. 37.2, what do we think? Check. 40, what do we think? Circle it, drop it. Even a really well-adapted athlete, we're not typically going to see 40. I'm not going to say never, but we're not typically going to see 40. 18, that's okay. Okay. 60 over 38. Yeah, emergency, right? Emergency. So let's circle that. And I want to come back to that blood pressure in one sec. And 90. Remember I said 90 is the absolute cutoff for that dissociation curve, right? That oxygen, hemoglobin oxygen dissociation curve. Because we know that is going to drop off rapidly from where it is. That's the minimum, but we're always providing oxygen at this point unless we have specific directions not to. And our goal is to get a 95 and above, right? So 90, we're gonna say not happy, that's low. Okay, now let me come back to this blood pressure. It's really, really important to recognize that there's some sort of rules of thumb. They're not like perfect, but there's some rules of thumb that are helpful. And I think one of them has always been helpful to me is understanding how adequately our body, when our body has a blood pressure of a certain range, how that is reflected in our pulses. So for example, if somebody is trying to take a blood pressure and they can't get a blood pressure, do you remember we listened to that story of Lewis Blackman, who had that very catastrophic admission to the hospital. And at one point, his blood pressure was not obtainable. They tried, I don't know, was it 10 or 11 or 12 times with 7 different cuffs? You don't need that. First of all, try to find a radial pulse. Again, rule of thumb, it is not perfect, but this is just something to tuck away. If you can palpate a radial pulse, typically, it means you have a blood pressure of at least 90. Now, I don't know if it's 190 or 200 or whatever, but typically if I can palpate a radial pulse, I've got a blood pressure of at least 90. So while I'm trying to get a whole bunch of things, I go to see a patient looks in distress, I can palpate the radial pulse. I know at least I've got a blood pressure of 90. I don't know what the upper end is. And it's not perfect, but let's just start there. If I can't palpate a radial pulse, I'm not going to go through all my pulses to see where they're at, but I'm going to walk you through a couple of them. If I go to, if I have a femoral pulse, then typically I'm going to have a blood pressure of about 70. So typically of about 70. And if I can feel a carotid pulse, typically I've got a blood pressure, hopefully of about 60. So if I don't feel a radial pulse, I'm immediately going to go for a carotid pulse. And if I can palpate, so it's not, can I hear a heartbeat? Can I palpate a pulse? And if I can palpate a carotid pulse, typically I've got a blood pressure of at least 60. So that's just a beginning point that's always helpful as a starting point when we're in an emergent situation and we're not sure what the situation is that is unfolding, and I want a whole bunch of information as I'm getting equipment, as I'm doing a whole bunch of inspection. So blood pressure 60 on 38, heart rate 40, O2 sat 90. What do I need to know? A whole bunch of things. First of all, I've got that rate of 40 and I have, but I don't have a rhythm, right? I don't know what the rhythm is. So it's really critical that I look at what is the rhythm, right? Yikes, rhythm. I've got a blood pressure of 60 over 38, critical, right? Now, it's really important here, and we're going to talk more about this in shock. The tendency when somebody has a blood pressure of 60 over 38, oh my gosh, I'm going to start running IV fluid, right? Lay the patient flat. I remember I told you, I think in the thinking bias of doing old things, doing something versus nothing, that we used to put their head down, put them in Trendelenburg. There's no good evidence that when someone is hypotensive, that's helpful, but flat is helpful. So we put a patient flat. I'm going to put them on high flow oxygen, right? Because I'm going to increase their oxygen saturation. Even if their oxygen saturation was okay, I'd still put them on oxygen because I see this heart rate of 40 and I'm not sure what's happening with their cardiac status. So I'd probably put them on some oxygen anyways. But I need to know not only their heart rate, but their rhythm. This all has to happen fast because I could have a failing heart that is decompensating, or a heart rate that has something like a heart block. We'll talk about that in many weeks, but something that is preventing impulses from being conducted through in such a way that the heart rate is very dramatically decreased. And because my heart rate is so dramatically decreased, I could have, my blood pressure is dropping, right? So it could be a primary condition that I need to treat in that situation with something to overcompensate or to compensate for that basic fundamental flaw, that error that is happening because of a cardiac rhythm, right? And we can see what the, the cause of that rhythm is. And so it could be that that's what's happening here. I also could have something like a cardiac damage related to an MI. And actually this might be the pattern I would see in something called cardiogenic shock. So I might see a tachycardia, but I might see this profound bradycardia as well. And in cardiogenic shock, it's so important. Cardiogenic shock typically can happen for several reasons, but typically will follow an MI. I really need to be cautious because if I start pouring that IV fluid into this person, they're not going to be able to cope with it. And actually, I speed up the process of decompensation. So I really need multiple people helping me here. I need to know what is the rhythm, not just the rate. And I need to be preparing for however I'm going to respond to this blood pressure. And you're going to be calling, of course, your either a co-team, a rapid response team, however you're going to be working through. This patient is critical. I remember I told you we're going to be putting some oxygen on, but also now let's look at this backwards. So we know that a heart rate of 40 can actually lead to that drop in blood pressure. Does a drop in blood pressure, does that go backwards? Does that drop in blood pressure lead me back to a low heart rate? So does a bradycardia come from a low blood pressure? No, that is not compensation. So do you see in this pattern, there's not a possibility. A low blood pressure does not lead to a low heart rate. If compensation were happening, I might have a low blood pressure and see a high heart rate, right? And that could be compensation that happens both ways, but a low blood pressure does not lead in a physiological compensatory rate to a low heart rate. So I can't see compensation going both ways. That's why it's important to think, can compensation go both ways or just one way? In this situation, we're seeing the process moving unidirectionally. that's where you have it. So we're going to, depending on the cause, we're going to lead to treatment. If this is a block, we may put an external pacemaker on the patient, and that will actually cause the heart to contract until we can probably put an internal pacemaker in. We may give medications that are going to speed up that heart rate. Again, depending on what kind of block, we may give medications that are, and we'll talk about that when we do our cardiac modules. If this is an MI, that the patient has experienced an MI and they're going to cardiogenic shock, I'm going to be looking at how can I support that person's blood pressure with medications. So some inotropes like a dopamine or a butamine or other kinds of medications that we're going to look at. So all of this is going to depend on what is emerging. I'm going to look for that rhythm right away. Immediately, I'm going to say to myself, I don't have enough information. And that's why as we move on from these vital signs, we'll move on to the cardiac modules and other things. But so important, at least in my mind, it's so important that we move through this step by step by step by step and see how we make our way through. Okay, I think I'm going to stop there with vital signs. Are you sick of this? Because I have to say, I do love them. I think they're like so undervalued, and the work of a detective really helps you to understand what the situation is, right? So it's so critical that we not actually have somebody else doing our vital signs, that we do our own vital signs if at all possible, and that we see the real value in them. Now I'm going to, let's see, turn this off. Let's see if I can screen share something else. I'm going to stop sharing for a second. And then I'm going to, oh my gosh, you got a big one of me. Now I'm going to try to screen share something else with you for just a second. Yikes. There are a lot of windows here open. Does this remind anyone else of their lives? And somebody's talking, so I'm going to ask them not to talk so much in the background. Okay, guys. Yikes, 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 yikes. What could be open on my page? Oops, can you, okay, bear with me for 1 second. Oh my gosh, I could share with you my family's recipes if you want. Okay, so let's try one more time, guys. And I am going to see if I can share my crystalloids. So give me a second. Oh my God. Here we go. Okay, so I wanted to just talk for a second about IV fluids. In the fluid and electrolytes lecture, I go over this, but this is where I just want you to have a really clear understanding of how we're using IV fluids, and to have that sort of mental picture of when and how you're using a various amounts. And so I talk about this a little bit. Let's go over it really quickly. Important that I just break this down into 3 categories. Maintenance rates. So you've got an IV in, you're not using it for any particular reason except maybe medications or something like that. You want to maintain the line. And so often we would be that TKVO to keep the line open. It's really important that you that we're watching the amount of fluid that's going in. We're always, look at the notes down there, going to query whether a lock is adequate versus running an infusion when it's not necessary. It also impedes a person's mobility. So we're always going to keep our mind open to whether that IV is necessary, but it may be. And so we want to look at what solution we're going to run through that at a TKVO rate. Now, I'm only going to talk about crystalloids here, and we'll talk about colloids later, but because you're most often working with crystalloids. And so that's your solutions that have actual particles in them, right? They have different things, glucose, electrolytes, sodium, things like that. Most often for a maintenance, we're looking at a rate of 25 to 50. Often it's just 25. You may be running it even lower. Again, we're looking adults, not peds. Most common solution we're going to see is D5. And sometimes we might see normal saline. The one, I put a question mark here beside normal saline because what we want to do is really watch for fluid overload, right? So we don't want fluid overload to happen, in particular with our cardiac patients. And you might think 25 cc's an hour is not very much. A normal saline is very prone to causing fluid overload, even at low rates. We're just going to pay attention to that. Some people have a real concern about D5W in patients who are diabetic. And I just want to put some brackets around that. So D5W really has enough, when we're running it at anything but a fluid resuscitation rate, it has enough glucose for metabolism. So if you think of a whole liter of D5W, that only has 200 calories in it, right? So 50 grams of sugar. It is not that you're giving so much sugar, it's enough for cellular metabolism. So just to pay attention to that, it's not such a concern if we're giving 25 cc's an hour. When we're looking at mild hydration, this is a person who's probably eating or drinking. They may be just moving up to eating or drinking. They may have a condition, pneumonia, something else. We might want to give them a little bit of fluid, but they're still, again, they've got other sources of fluid. Common solutions, most common solutions. So we could use D5. I'm sorry, I didn't put normal saline. Can I add it to this sheet here so that you see it? There, normal saline. Sometimes we can see normal saline as a mild hydration as well. Most commonly, we're going to see for mild hydration, something like 2/3 and 1/3, and we're going to be running that at 50 to 75. Where there can be some really judicious reasons why we might be using, moving to a mild hydration rate, that 50 to 75. Remember, this is not for someone who's NPO. One of the biggest mistakes we make is that a patient's NPO and we're thinking, oh, I can just run this at 50 to 75. That's not enough fluid for a person to carry on with, right? So 50 to 75, this is mild hydration. So typically a person is getting fluid from other sources at the same time. And most commonly we want 2/3 and 1/3. So 3.3% saline, 3.3% dextrose, 0.3% saline, 2 3s and a 3. It is the most common solution that we're going to see there. You've got a little bit of saline, we've got a little bit of dextrose for cellular metabolism, okay? So one of the really judicious ways that we do that is when a person is moving from being NPO to being, to having initiation of oral intake, we may actually leave their IV in and lower the rate of their IV, because if we keep running the IV at a hydration rate, you know, that, and we'll talk about that in the next column, 100 to 150 cc's an hour, that one of the challenges is that a person may not feel thirsty because they're getting adequate fluid through their intravenous. So we may actually drop that IV rate to challenge a little bit of thirst. Again, always watching in and out and seeing where the patient is at, and looking at not just their in and out, their intake and their output, but also their renal status. Moving to hydration, again, we're looking at 100 to the upper end, 150 cc's. Typically, we're going to see 100 to 125. Just to let you know, 100 to 150, but commonly 150, I'm always going to pay attention to that. I'm going to bracket a little bit, 100 to 125 most commonly. And that's going to be for someone NPO. NPO, you're always thinking, are they getting enough fluid? You're not going to be putting them into fluid overload, but are they getting enough? For a person who needs a hydrating fluid, now you might notice almost all of these, everything we're talking about here is isotonic. That means I'm not processing fluid shifts in such a way that that I'm drawing fluid in and out of different compartments. I am just at this point providing some basic solutions. 3 most common solutions we're going to see for hydration. We're going to see normal saline, 2/3 and 1/3, and Ringer's lactate. So normal saline, you've just got saline, 2/3 and 1/3, you've got a little bit of that glucose, and Ringer's lactate, you've got some electrolytes in there. Most often where you'd see Ringer's lactate used maybe in the emergency department or the ICU, surgical ICU, and most often perioperatively, post-op, perioperatively, intraoperatively, and post-op. You're going to see that. It's important here that one size doesn't fit all, that a frail older person with a fragile cardiac condition you may be very cautious at even giving 100 cc's an hour, but you're not going to let that person become dehydrated, but you're going to assess them very much. Another patient may easily tolerate 125, 150 mils. You're also going to look at the specific medical conditions. And this is an odd one. I think I talked about it in the other lecture, but a little bit close to my heart, because there are some patients that have specific medical conditions that are going to dictate the fluid. And the one in particular that always comes to mind for me is patients with ascites. When a patient has liver disease and has ascites, what happens is those albumin molecules, right? Like, so those protein molecules, that albumin, leaches through the capillary membrane there, and it ends up in that peritoneal fluid, right? So it's full, that peritoneal area is full of that albumin-rich fluid. And because you have all of that albumin-rich fluid there, if I give a solution like normal saline, what'll happen is that albumin-rich peritoneal fluid will draw that more fluid into it. All those big albumin molecules draw more fluid into that peritoneal, and the amount of fluid that somebody has, that ascites, just grows and grows and grows. So this is one very anomalous, very unique situation where for hydration, you may only use D5W for patients with ascites or acute liver disease. And even for fluid resuscitation, this is very rare. Only in this kind of patient, typically, would you ever see that you may actually use D5W if you're doing a fluid resuscitation. For example, sometimes there's a rupture of a periumbilical abscess, and that you'll have that herniation. That herniation may rupture, and you have that fluid leaking in a patient under different circumstances. If I was passing a lot of fluid, and that fluid I was at risk for becoming hypovolemic, you would give a hydrating solution. In this case, because of that fluid shift that innately happens because of those albumin molecules, you're sticking to D5. Very anomalous, but that's just sort of an example that validates how you have to understand their medical history. No one solution fits everybody. Finally, fluid resuscitation. We're looking at boluses, typically anywhere, sometimes even 100 cc's, but typically you're looking at 250 to 1,000 mils over an hour. You may look at running that IV continuously, just wide open, to try to resuscitate someone. Watch for what other options may be available. Also watch for dilution. When you're looking at a person who is may have a trauma, and they may have a low hemoglobin, let's say they're bleeding from heart, as you're pouring that fluid in, you may find that you're diluting what hemoglobin they have left. So you have to really be cautious about that. So again, solutions, we're going to look for that fluid resuscitation typically, unless we know something else, would be normal saline or Ringer's lactate. And oh, I've got a typo there, but one of the things we're going to really watch for is there a way to pull out fluid that we need from other parts of the body, as opposed to just pouring in extra fluid. And that's where you're going to see 3% saline used in situations like that, where you're actually using the body's fluid as opposed to just pouring fluid in. Very atypical. You're not going to see that on a regular unit. You're not going to see that kind of fluid on a unit. Important. I'm going to come back just to the same message I've been making. One size doesn't fit all. You need to know someone's status. You're always going to be watching their cardiac status. And that means you don't want to overhydrate them, but and put them into fluid overload, but you also don't want to give them enough. I remember when I took my first ACLS class, I killed my patient because all she needed was another bolus of 250 mils. And I was so afraid. The case study was a patient who had a low blood pressure, and I gave her a bolus, then I gave her another bolus, and I didn't know what else to do. And she just needed another bolus. And I was so afraid, that cliche that I'm going to put her into fluid overload, that I didn't react properly. A couple of notes here, and then we're done. One thing, all IV fluids, typically you're going to run them by pump, right? Safety considerations, everything's run by pump. If you've got anything in that IV fluid like potassium, for sure it must be run by pump. Most often we're running isotonic IV fluids. I know we teach you about hypertonic, hypotonic, isotonic, but most often we run isotonic. I talked about D5 already, and so we really want to watch about that. And I think that's it. I think we're good. I think that's it. And I hope you found that helpful. Let's see where we're at. I'm going to stop now, and I look forward to meeting you in class, online, of course.